on issues of health with Dr. Alcena. For this segment of the show, I'm going to continue to talk about sickle cell disease. Sickle cell disease affects people throughout the world, in particular black folks. And in this country, roughly 100,000 people suffer from sickle cell disease itself, the homozygous type, and about 3,600,000 folks carry the sickle cell trait in this country. Worldwide, there are 300 million folks who have sickle cell trait. And to give an example, in Nigeria, there are 4 million people with sickle cell disease. It's a very, very serious disease. Before I continue, however, I want to share with you this book that I wrote. It came out about almost 2 months now, The Best of Clinical Medicine for the 21st Century. It's a very big book. It has 110 chapters, 816 pages. You could find it in your local public libraries as well as online, wherever books are sold. There are always some copies as well in my office. This book covers medicine not just for the 21st century in the United States, but covers medicine throughout the world. Take a look at it. A lot of material in there. It is written in a format that is easy for the general public to read as well and understand, as well as for the healthcare professionals. Now, when I left up last week, I was speaking about hypoplastic crisis. Hypoplastic crisis is a sickle cell crisis that develops when suddenly the bone marrow stops producing red blood cells. There are a list of different types of crises. I will enumerate them for you. You have hemolytic crisis, painful crisis, hypoplastic crisis, priapism, splenic sequestration, acute chest syndrome, etc. Those are very serious problems that people can present with acutely who are suffering from sickle cell disease. Now, hypoplastic crisis is a condition in which whereby the person presents either with an infection that can be recognized or an occult infection, what have you, and suddenly the extent of the infection suppresses the ability of the bone marrow to produce red blood cells. And the way one discovered that is that when someone has sickle cell disease, they almost always, 100% of the time, except when they have this syndrome, hemolyzing. And when somebody is hemolyzing, regardless the cause of the hemolysis, the body's attempt is to replace the red blood cells that are being destroyed with new red blood cell called reticulocyte. Okay? The reticulocytes are baby red blood cell. Now, the normal red blood cell in the human body lasts 121 days. In the sickle cell disease patient, the sickling cell, the sickle cell, which is this banana-shaped cell that you're looking at here, half-moon banana-shaped cell, these are the sickle cells. You see how bad the shape is. And these cells can last in the body anywhere from 20, 15 days in that range, 30 days in that range, because they don't live very long. And because of that, you have all this problem associated with sickle cell disease. This is the size of a normal red blood cell right here. And the red blood cell is this shape, which enables it to squeeze through different calibers of vessels throughout the body to carry oxygen. But the sickle cells cannot do that. They cannot do that because the shape of the cell, plus the cell is very sticky. And when the cell gets inside the vessel, it gets stuck in there, and it's very difficult for it to navigate through the vessel. And then the sticking of the cell to the wall of the blood vessel causes a local reaction as well, which causes an inflammation to develop, further making the situation worse. Okay? And the sickle cell disease that we know it, the clinical disease, was discovered in 1910 in Chicago by Dr. James Herrick, happened to have been a cardiologist who was treating a young black fellow, in those days we call him NEGRE, from the island, from the Caribbean. And then this guy presented there with this very, very sick, and this doctor that was very astute happened to take a look at his red blood cell under the microscope and see the sickling cells, and then hence the knowledge that clinical sickle cell disease was diagnosed in 1910 in this country. Okay, Now, this young man was from the island of Grenada. He was here studying to become a dentist. Now, the genes that cause the disease, sickle cell, there are three of them. They are Ben from Benin, they're Ka from Central Republic of Africa, and then they are Sen from Senegal. These are the three main genes. Depending which place in these three areas that the slaves were taken to take to wherever they were taken to, Europe, Central America, South America, the Caribbean, and this country, United States of America, wherever, this particular groups of slaves would have carried this disease with them. Okay, so sickle cell is found throughout the world because there were slaves that were distributed during this terrible episode in human whatever, all over the world. Okay, you go to Rome, they show you all these incredible buildings and all these things. They were all built by slaves. It's unbelievable. The cruelty, and they were paid nothing. They barely fed them. So this is the cruelty of human to one another. Okay, so of the all animals that exist in the world, human is the most cruel. The most cruel, because what makes humans so cruel is their ability to think. And when somebody is bad, they think of the worst thing. They do the worst thing to one another. And of course, human, as I said, I will repeat that, of all the animals God created in the world, a human animal is the most cruel. Other animals in the wild, if you don't bother them, they don't bother you. Okay? But human go after you for whatever reason to do damage to you or do all sorts of stuff. What's going on? We're living in a sick world. So therefore then, this is a background of the sickle cell. To go even further, I can mention that Dr. Lannis Pauling actually discovered the abnormality that causes the cell to sickle. When you go to the hemoglobin chain, there's a substitution from valine to glutamic acid. That single substitution causes the cell to become abnormal, hence the discovery of sickle cell disease, and of course, the entire modern world of molecular biology, molecular genetic, molecular pharmacology, etc., molecular genetics, all came out because of this singular research that was done on sickle cell disease. So as awful a disease that sickle cell disease is, this particular disease lead the way to the knowledge. Everything that's happening right now, all this DNA stuff they're talking about, all because of this singular research that was done first by Dr. Pauling. Of course, he got the Nobel Prize for that. So now, when the bone marrow fails, how do you find out? Well, what we do is that, as I said, one of the most important tests, in fact, the most important test that you have to do, in addition to evaluating the total red cell volume of the patient, is to do the reticulocyte count. What are reticulocytes? They're baby red cell. How do you know that they're baby red cell? Well, the red cell, this red cell is mature. Because it is mature, it is not bluish. It has already gotten rid of the DNA and RNA that was in it. When the red cells are very young, and I don't have something to show you here, when you stand them, they become very bluish. Why? Because they're so young, they call them megakaryocytes. They still contain remnants of RNA and DNA that's yet to be gotten rid of. But as the red cell mature, by the way, the younger the red cell, the bigger it is, okay? And the more mature the red cell, the smaller it is, like this, okay? This is a normal size red blood cell with this shape right here, okay? So when that happens, we will then take blood from the patient, either from the finger or from the vein, and we will smear it out on the smear, stain it with gram Giemsa, let it dry, put a little drop of oil on it, put it under the microscope, cover it with a little covering material, glass material, and then look at it under the microscope. And the idea is to count 100 red blood cells. And if the amount of sickle cell, the amount of bluish red blood cell that is found within 100 red cell that one counts, That is the percentage of reticulocyte. Now, a sickler, be it whatever the sickling disease they have, and I will repeat them to you, is supposed to be walking around between 5, 6, 7, 8% of sickle cell all the time. The normal sickle cell in somebody who's not hemolyzed and who has sickle cell disease is up to 1.5%, 1.3, 1.5%, okay? All right, so that tells you the patient is alive, he or she bone marrow is functioning because the bone marrow is able to make new red blood cells to replace the ones that are being destroyed as part of this hemolytic phenomena, okay? Now, the problem is when somebody comes in, they're very sick, you do a blood count, you do a reticulocyte count, the comeback is less than 1. That's crisis. Not only that, it is hypoplastic crisis, but it's a medical crisis. You really have to roll up your sleeve and quickly recognize what's going on and get into action to save this patient's life. You try to find out the source of the infection, if it is an infection that's causing the problem, but you must immediately begin treating this patient after you do all your evaluation with red blood cell transfusion and high dose folic acid, and you try to treat the underlying problem that's causing the hypoplastic crisis, if you can, if you have identified it. Sometimes we can't find it, and the patient over time recovers. So you have to maintain the patient by giving the patient red blood cell transfusion. And as I mentioned, I will mention it again in previous shows, when the patient is this sick, because if the patient has sickle cell disease, he or she has brain disease, eye disease, heart disease, kidney disease, gallbladder disease, and so on and so forth. So because you have vaso-occlusive condition, whereby these red blood cells are occluding the blood vessel, preventing oxygen from being delivered to these different organs. In fact, science have shown situation whereby we see damage occurring in fetus while they're still in the mother's womb who have sickle cell disease. That's correct. So therefore, it is inevitable. If someone has sickle cell disease, they're going to have ischemia of the brain, ischemia of the heart, ischemia of the eyes, ischemia of the kidney, because the red blood cell cannot sufficiently carry enough oxygen to perfuse this organ. That being the case, then, you need this patient automatically will have what's called the oxygen dissociation curve shifted to the left. And when the oxygen dissociation curve is shifted to the left, you say, well, what is the oxygen dissociation curve? It is an invisible curve that we scientists and physicians know about. If you wait in the middle right here, there's the left and there's the right. Once the curve is shifted to the left, whatever little oxygen that this red blood cell have is going to hold on to it for their life. It's not going to discharge it to the rest of the body. This is not fancy science, this is fact. Now, as soon as it is shifted to the right, at which thing the red blood cells are now capable of delivering the oxygen to wherever it's supposed to go. All right, so far so good. So that being the case, then you have somebody who's this sick, who's got underlying ischemic disease throughout the body. It is the job of the treating doctor, and I hope it is a hematologist, because you can't treat this on your own. That's going to go to the blood bank. You speak to the blood bank technicians, saying to them, I have a sick patient, a sickle cell patient that I have to transfuse that's very sick. I need for you to give me, if you can, red blood cells that are between 1 week or 2 weeks old, max. The red blood cell is allowed by rules and regulation to stay in the blood bank up to 42 days. I'm not just speaking as a physician, as a hematologist, but I'm also speaking as a medical ontologist, medical technologist. I spent years struggling in the blood bank, the hematology lab, all the other labs, 8 different ones. I have dashes in 8 of them that I work preparing blood all night, all day. Okay, so I know this stuff cold. Therefore, and the reason for this is because as red blood cells sit in the blood bank after it was taken from the donor, by necessity, It can't help it. There's a substance called 2,3-DPG. Those red blood cells contain 2,3-DPG. That's what keeps them fresh. The higher the level of 2,3-DPG, the fresher the blood. The lower the level of 2,3-DPG in the blood, the less fresh the blood is. Okay, fine. Therefore, if someone were to take 2,3-DPG deficient blood that's been there maybe 3-4 weeks, 5 weeks, whatever, and you transfuse it into a very sick, sickling patient, in particular someone who presents with hypoplastic crisis where they're not making red blood cells to begin with, you likely could create a catastrophe, from a crisis to a catastrophe. You say, well, how so? Well, I just explained to you. As you transfuse this 2,3-DPG deficient blood into the vein of this patient, it's going to shift the oxygen distribution curve farther to the left than it was already was, or whatever. Therefore, making the patient acutely more ischemic than he or she was. That can precipitate a stroke, and it can precipitate a heart attack, and for that matter, it can precipitate acute kidney failure. Okay? And I want you to understand that I do not have a monopoly to this information. If people don't know it, that's their business. None of my business. Because fact, this is scientific, clinical fact, that you better know these things if you're going to take care of people whose life they entrusted into your hand at the moment when there's no room for error. Therefore then, if the tech understands what you're saying and gives you the blood, and you have the right to ask for that blood, and blood is very precious, you're not wasting it, you just want to save a patient's life, then you will transfuse the patient with blood that has ample quantity of 2,3-DPG, the fresh blood. Automatically the oxygen dissociation curve is shifted to the right, and this blood is going to carry sufficient amount of oxygen to perfuse the brain, the eyes, the heart, the lungs, the kidneys, and all the organs. And then you maintain this patient for transfusion. You do blood count every day. You check the reticulocyte count every day. And then, in addition to that, you must, let me repeat that, you must give the patient intravenous folic acid. Not in small quantity, in large quantity. The maximum dose of folic acid that is allowed to be used in medicine, listen to this, is up to 25 milligrams. Let me repeat that. The maximum dose of folic acid that is allowed to be used in the field of clinical medicine, as outlined in several textbooks of hematology, is up to 25 milligrams. And the nutritional dose of folic acid is 1 milligram. As a matter of fact, even the 1 milligram is too much, because the way our body is made, naturally, if we're not hemolyzing, we cannot absorb more than 400 micrograms of folic acid per day. We take 1 milligram because that is how it is made. They don't make it smaller than 1 milligram. But we know the body cannot absorb more than 400 micrograms. Okay? So you give 1,000 micrograms. If you don't know that, that's your business, none of my business. But that's the way it is. However, when somebody is hemolyzing, you can't even count the folic acid, because everybody who is hemolyzing, no matter the reason for it, is relatively folate deficient. Because the body, first of all, folic acid is very labile to begin with. And as the body is breaking down red blood cells, the body is looking all over for folic acid to try to produce new red blood cells. Without folic acid, and God knows a lot of other stuff, you can't produce proper amount of red blood cells. But the first thing the body needs, believe it or not, is folic acid, because folic acid it can disappear within hours. Folic acid can last for days. That's it, max. 1 week max, okay? Because if I put you deficient for folic acid for a week, and this science was done by a doctor who unfortunately passed away that used to work at the Bronx VA, by starving people of folic acid and sticking their fingers every day, making a smear, and see how many days it takes for the red blood cell to become enlarged and larger and larger and larger and larger. See, so it's labor, and this is non-science again. Don't have the monopoly to it. If you don't know it, that's your business, not mine. Because what's done is it is in the literature. I happen to have known this doctor personally. He trained at Montefiore, where I also trained. He was, of course, an older person, but nice guy. Used to come there and give lectures or whatever. Unfortunately, he passed away. So this was done. So folic acid is very labile. So the more the patient is hemolyzing, the more you have to give them between 4 milligrams of folic acid intravenously 4 times a day. That's what I do to keep up with what's going on. And the patient is not making red blood cell, you try to maintain them by giving them fresh blood, give them nasal oxygen, fresh red blood cell to acutely, and acutely try to find out the source of the problem that suppresses the bone marrow to begin with. Sometimes we can. If it's a bacterial infection, we could treat it. If it is a fungal infection, we could treat it. It's a viral infection, maybe, maybe not, depending what kind of virus it is, and so on and so forth, okay? So that's how we handle hypoplastic crisis. But you have to be aware that it can occur. And the simplest, cheapest test that you could do to determine if it exists or not is a reticulocyte count. You get it for nothing. You just ask for a complete blood count and you attach reticulocyte on it. You get it within hours. Okay? People like me, I can go to the lab and look at it myself because I'm a medical technologist. But other doctors who don't have the laboratory facilities that I have, because I worked in the lab for years, you just ask, you get a report. The report can be given to you within an hour. It's not a big deal. Less than that. All you have to do is stand it on the slide. It's thin, it's dry, you look at it. No big deal, but it is crucial, okay? All right. So enough said about hypoplastic crisis. Now let's look for another crisis, which is also quite common. And again, for a reason that is not clear, okay? Everyone with sickle cell disease, and there are 4 types of sickle cell disease as we know it, medically, clinically, syndrome. You have sickle cell trait, you have SS, which is the homozygous from sickle cell SA, then you have sickle C, and you got sickle thalassemia. Those are the 4, okay? Those are the 4. Keeping in mind that individuals who have sickle cell trait still have a spleen in situ. Individuals who have hemoglobin SS, likely by the time they reach adulthood, they have no more spleen. The spleen has been destroyed by the sickling phenomena, okay? People who have SC disease still have a spleen. People who have sickle thal still have a spleen. Very important to remember that. Very important. In fact, sickle cell trait also can cause serious problems because people who have sickle cell trait, they can also destroy the spleen, okay? They can destroy the spleen. Because sickle cell trait, they never used to take folks into the armed forces who had sickle cell trait. They used to discriminate against these folks. Okay, they didn't take them because they had sickle cell trait, blah, blah, blah. They claim, so they say, that they could rupture the spleen during the problem in the plane. They use all kind of sort of stuff to, and most of it was bogus, to try to keep these black folks out of the armed forces, whatever, okay? All this crazy stuff happened in the past. So, sickle cell trait has a spleen, sickle cell C has a spleen, and sickle cell thal has a spleen. What's the importance of that? Extremely important, because one of the most common symptoms that people with sickle cell disease present to the emergency room is abdominal pain. Severe abdominal pain, pain all over, but abdominal pain. You want to make sure that these individuals are not infecting the spleen. So right away, you have to put that in the front of your mind. If they have SS, they can have a lot of other problems done with the inside the abdomen, but it's not going to be the spleen that's going to be ruptured because there is no spleen. The spleen has been destroyed by the sickle phenomena from childhood until adulthood. That is the reason why we prophylax these individuals with pneumovax vaccine, and we prophylax them with daily penicillin to prevent pneumococci, which is one of the bacteria that get they get infected with very easily. That's the purpose of it. Okay, you give them a vaccination, you give them a shot of Novavax every 3 years, and you put them on penicillin 250 milligram 4 times a day, every day. If they're allergic to penicillin, you put them on erythromycin. That's the prophylaxis for sicklers. Okay, I'm telling you, even though before I get to talk about treatment, which I will. So the point is, the next problem that we're having is the so-called priapism. What is priapism? Priapism is a condition during which this cell, this sticky, mouse-shaped sickle cell, gets stuck in the circulation of the man's penis, resulting in an acute, severe, painful penile erection that can last for days. And they have to go in there sometime. The urologists have to go in there sometime put local anesthesia and use a needle to draw blood from the vessels around the gland to try to remove as much of these cells as possible to try to decrease the extent of this problem. And it's not easy. It's very painful. People are walking around there. In fact, the poor guys cannot even sit down. They're walking and jumping in pain. So that's called priapism, okay? Then on top of that, you have other situations where people will ghostly bleed from the penis, or for that matter, ghostly bleed from the bladder in the female or in the man as well, because of the sickling phenomena. And that happened because the sickle cell, this cell gets stuck in the papillae of the kidney and causing what's called papillary necrosis. And papillary necrosis then occurs because the kidney sits at different level on the abdomen. And the higher the kidney, the less oxygen it gets. And this is why you get this situation. Listen, I'm going to stop here. I'll continue to talk about this next week. Until such time, keep watching the show. This is Dr. Alcena saying so long and bye-bye.